interest in it for a long, long time, and I'll give you a little bit of history. When I was in Australia doing my fellowship in 1985, Merv Cross, who was the orthopedic surgeon that I was working with, he was doing a lateral extra-articular tenodesis, which we'll learn a little bit more about back then, and doing a primary repair of the ACL. Well, as y'all all know, repair of the ACL does not work. But what was fascinating about the lateral extra-articular tenodesis, although it probably over-constrained the knee a little bit, it absolutely got rid of the pivot shift. So as we've learned more and more about the anterolateral ligament, or the lateral ligament complex, or whatever you want to call it, it is a fact. There is something on the lateral side of the knee that seems to control rotational stability more than the ACL. And I was reading an article this morning from the January 2021 issue of the American Journal of Sports Medicine, and they said, and as you know, we're supposed to practice evidence-based medicine, right? So what they showed in that article is, of the cadaveric studies that have been done on the ALL in the last decade, the range of the ALL being present in those cadaveric studies have ranged from 0, it was never there in the cadaver, to 100%. So one of the studies showed that every single cadaver they dissected had an ALL. So how in the hell are we supposed to practice evidence-based medicine if one study says it does not exist and another study says every cadaver had an ALL? So that's the state of the ALL right now. What this article was talking about is comparing the biology of the ALL and the anterolateral capsule. And they were looking at it morphologically and under the microscope. And in this cadaveric study, of the 25 specimens, only 3 had a defined ALL. The others had a thickened anterolateral capsule. And so what a lot of the papers seem to show is that the ALL is very similar to the inferior glenohumeral ligament. Because as you know, the inferior glenohumeral ligament isn't like a true ligament. It's just a real thickening of the capsule, and structurally it acts like a ligament. So if I sound like anywhere near know much about the ALL, I'm fooling you, because I really don't know a lot about it, because the literature is all over the place. But the take-home lesson, if you learn anything from this lecture, is that there is something on the lateral side of the knee that seems to control rotational stability more importantly than the ACL. That's number one. Number two is we should not treat all ACLs alike. I guarantee you, each and every one of you athletic trainers have examined some knees and you go, crap, that is loose. And you've also examined some knees and go, nah, I think that ACL is okay. And then you got the MRI and the ACL was out. So we know that anatomically everybody is different. So kind of the important point of this talk is, let's don't treat all ACL injuries the same. Because this, as you see in the title, is an athlete-specific option in your therapeutic arsenal for treating ACL injuries. That was a long opening comment, wasn't it? We good? No worky. Okay, so our learning objectives, just history, anatomy, structure, and function of the ALL, a little bit about operative indications, and then some of our results. So Paul Sagan was a French surgeon who discovered it back in 1879. Just talked about this thin, kind of thick tissue on the lateral side of the knee that seemed to be associated with internal rotation injuries. And really everything blew up in 2013 when a Belgian surgeon named Kleis did a bunch of dissections and actually said that, and called it the anterolateral ligament. And I'll never forget being in New York at a meeting, and you know, you get in the cab and they have those little TVs, and there was a little blurb on the news, new ligament discovered by Belgian surgeon. I'm like, that's kind of interesting. So actually the term, the lateral capsular sign of the Sagan's fracture, was Bill Woods in Houston back in '79. So if you look, I don't have the, so Sagan in '79, Jack Houston, and that '74 article, one of the co-authors of that article is Merv Cross, who was doing a fellowship with Jack Houston in Columbus, Georgia. And then they described the lateral capsular sign by Woods in '79. And then the other interesting kind of tie-in is this guy, Corky Terry, in Houston in 1986. Corky Terry was a resident here back in the 80s. So we'll talk a little bit about the role of the lateral extra-articular tenodesis, because that was what was going on in the mid-80s to about the mid-90s. And I was actually at that SNOMAS conference in 1989 when the AOSSM decided, hey, we probably shouldn't be doing lateral extra-articular tenodesis anymore because they may over-constrain the knee. Because you got to remember, in about the mid-90s, early 90s, it was all about arthroscopic ACL reconstruction, and we kind of forgot about the lateral aspect of the knee. So it kind of went out of favor for almost 2 decades. So here are a few of the procedures. The Ellison procedure, you just take a strip of the iliotibial band and you run it under the fibular-collateral ligament, trying to create a kind of a dynamic lateral extra-articular tenodesis. The Lemaire procedure, you're taking the ITB off proximally, you run it under a bony tunnel. And again, as we move through these procedures, you look at the McIntosh. So what you see is you're trying to recreate something on the lateral side of the knee that runs from the lateral femoral condyle down to the lateral tibial plateau, which is kind of where the ALL is. And then the McCaughey procedure, it's an intra-articular ACL reconstruction, and then you bring the hamstring tendon down and kind of reconstruct the ALL. So a little bit about the qualitative properties. Probably the most important thing for y'all to know about the ALL, or whatever that ligament is called, is it's uniquely involved with the lateral meniscus. So there's been a number of studies that have shown that if the ALL is injured, the lateral meniscus becomes more mobile, and then I'll show you some slides of some some arthroscopic pictures. So here's the anatomy, and if you look at this picture, this particular drawing I got on my fellow, and I got to give a shout out to Chris Maltsakos, our ex-fellow, who helped put together this talk. But this is a little bit of an older, do we have a pointer? This is a little bit of an older picture. That ALL in this drawing is a little bit too vertical. So if you see the origin, go up to this one over here. So the top of the ALL right there should move a little closer to the origin of the LCL, or the fibular-collateral ligament, going straight up. So move it a little bit posterior. And some of the studies more recently seem to indicate that maybe the structure actually has its origin just posterior to the origin of the fibular-collateral ligament. But again, the anatomy is all over the place. Suffice it to say, it's a little bit more oblique than in that picture. And we don't need to go over a whole lot of this. It's basically about 35 millimeters long. It's about 8 millimeters in diameter until it gets down to the tibia and it gets a little wider. So there's some little bit better pictures. I think the one at the top is fairly accurate. So you see the lateral collateral ligament going fairly horizontally. I think the most important thing to know about the anatomy of the ALL is it runs obliquely, kind of like the M doesn't go straight up and down. It goes from posterior to anterior. Posterior on the femur, and a little more anterior on the tibia. And this is just kind of a good slide to show how close it is to the lateral geniculate artery. And this was kind of an interesting study. A guy from Italy was talking about how important that it was for rotational stability. And actually, in some of Kleiss's original work, he would amputate the ALL, amputate the ACL, and then amputate both. And what he showed is that if you do an isolated resection of the ACL, there is a pivot glide. If you do an isolated resection of the ALL, there's a pivot glide. And if you do both, there's a pivot shift. And this was just another kind of study that talks about how important the ALL is related to the pivot shift in rotational stability. So load to failure, this study just shows kind of the most common injury to the ALL when you load it to failure. 4 on the femoral side, 1 on the tibial side, 4 mid-substance, and 6 of the Sagan's fracture. Has anybody seen an X-ray of Sagan's fracture? A little fracture on the lateral tibial plateau. I'll show you a picture of an X-ray. So, what does this all mean? So, our question for us is: will adding an ALL reconstruction to an ACL reconstruction improve stability in a less invasive manner than a lateral extra-articular tenodesis? So this is a friend of mine from Lyon, France. He and I operated together. Went over there and operated with him, and he came over here and operated with me. And he probably has done more ALL work than anybody in the world. And what he showed is that if you look at the bottom line, for isolated ACLs, hamstrings, the failure rate, this was about a 2.5-year study, the failure rate was about 11%. For BTBs is about 17%. And if you added an ALL, it went down to 4%. So you're decreasing your failure rate by almost 50%. That slide was supposed to have been removed. So what does it do for patients who have chronic ACL deficiency? And I'd be willing to bet that a lot of y'all have seen patients who've had an old ACL and their knee is really, really loose. And we know that over time, as you start to stretch out your secondary restraints with multiple instability episodes, the knee gets looser and looser. And what the studies do seem to indicate is that adding an ACL in somebody who you're reconstructing chronic ACL insufficiency seems to improve the results. The main thing to look on this one is look at the very bottom. The re-rupture rate or residual pivot shift without the ALL was 35%. With an ALL was about 10%. And then we all, I mean, again, I'm relatively sure a lot of y'all have seen a 16-year-old female volleyball player who her elbow hyperextends, her second MP joint of her finger goes straight up, her knees hyperextend, so she's got generalized ligamentous laxity. And we've known for years that patients with generalized ligamentous laxity seem to have a higher increase of failure of ACL reconstructions. Even to the point in the probably mid-2000s, because women had a much, much higher risk of having generalized ligamentous laxity, when we were still doing ACL reconstructions using allografts, people said, I don't want a female allograft, I want a male allograft, because you had less laxity to it. But it does seem that in patients that have generalized ligamentous laxity, adding an ALL decreases their risk of failure. Re-rupture rate going from about 26% to about 3%. So revision ACL, and this is, for me, this is one of our real problems. What do I do with somebody who comes in, they've had an ACL reconstruction, it ruptured, even if it was done technically correct? As y'all know, that the most common cause of failure in ACL reconstruction is technical misadventure, i.e. putting the femoral tunnel too anterior or putting the tibial tunnel too anterior so that the graft is not asymmetric. But even in patients who have a well-placed graft, what do you do in somebody when they re-rupture? Well, these studies seem to indicate that adding an ALL to a revision ACL decreases the re-rupture rate. And that's kind of been my experience. In fact, for my own practice, if you have an ACL graft rupture, you're probably, in my hands, almost always going to get an ALL in addition to the ACL, unless you don't have a big pivot shift. So meniscus repairs. The literature over the years has basically said if you do a meniscus repair in the face of an ACL reconstruction, the failure rate is very, very low, because if you think about it, you're drilling into the femur, you're drilling into the tibia, you have all this bone marrow invading the joint, all these stem cells, so it creates a very ripe environment for meniscal healing. But we do know that there is microinstability associated with an ACL reconstructed knee, and it does appear that adding an ALL in patients that you're doing a meniscal repair improves the results. And Bertrand Sonnery-Cotet showed that in this article in 2018. Again, that was, I don't even know how to interpret that. So what do we make of all this? So currently my criteria for ALL is ACL revision, a big pivot shift. And I'll show you some good MRI examples of that. Young patients under the age of 30, any kid that's skeletally immature, because we know that their failure rate is substantially higher. And the reconstructive techniques, you have to alter a little bit, so I add an ALL to those. Every female point guard that I see gets an ALL. No question about it. We did a study about 10, 12 years ago looking at position-specific risk. Female point guards are at very high risk because there's so much more sagittal movement in those versus a post. Concurrent meniscal repair, chronic ACL ruptures. If I see a patient who had an ACL on one side and it failed, and they have a new ACL, let's say they have a failed ACL on the left, they have a new ACL on the right, I'm going to do an ALL on that new one. And then patients with generalized ligamentous laxity. So there's a classic pivot shift. So what happens, oh, can I use this? Oh, am I off line? So, where's the mouse?
Keep moving it, it'll find it. There it is.
So what happens is, when you rupture your ACL, the lateral tibial plateau dislocates, not the whole knee. Remember, it's a rotational injury. So the lateral tibial plateau rotates out from under the femur, and when it comes back, the back of the tibial plateau hits the front of the femur. And that's what causes this little dent. You can see this dent. See that little dent in the in the subchondral bone? And you can actually see it on the x-ray. Giving me this computer is like giving a hog a wristwatch. So if you see that on MRI, patient has a big pivot shift injury, then you have to suspect that the ALL has been injured. So there's a pivot shift injury. The articular cartilage got whacked on the lateral femoral condyle. There's a bad articular cartilage injury. And these are the meniscus tears that you see in patients who have an ALL injury. Remember we talked about earlier, the ALL is intimately attached to the lateral meniscus. So when you pivot, if you tear the ALL, the meniscus is now more mobile, and it gets caught between the femur and the tibia, and you almost always get this radial tear right in the middle of the body of the lateral meniscus, and then sometimes a little root tear. If I see that on arthroscopically, I know for a fact that the ALL has been injured. So again, another posterior horn tear of the lateral meniscus, same picture. So there's a Sagan's fracture. So if you imagine, this is obviously a skeletally immature kid. If you imagine that the ALL attaches to the lateral tibial plateau, and we all know, we've all seen tibial eminence avulsions where the ACL pulls off a chunk of bone. It's almost always seen in skeletally immature kids. Well, this is the same concept. The ligament pulls off a chunk of bone, and so the ligament is still attached. It's not a ligament injury, it's a bony injury. The ligament is attached to the piece of bone, so you whack a screw in it and then reconstruct the ACL. So I'm not going to go through this surgical technique in detail, but I'll just show you. Now, Mark, can y'all make, this is a video?
Yes, sir.
Can you make it run? Because I guarantee you I can't make it run. So here's a pivot. Woo! That's a pivot shift. So obviously if I see that exam, that kid's going to get an ALL. Now, we'll go quickly to the technique. So basically you find your landmarks, kind of lateral epicondyle of the femur, lateral tibial plateau, about 5 millimeters distal to the joint line, halfway in between Gerdy's tubercle and the fibular head. We confirm our location of our guide pins. We fix the graft to the femur using a bioabsorbable screw into a little tunnel. Then we run it under the iliotibial band. Remember all of those lateral extra-articular procedures I showed you earlier? They all involve something going under the iliotibial band or using a piece of the iliotibial band to go around the lateral collateral ligament. Now you want to run this one for me, Sean?
Yes, sir.
So this is a patient, I have not reconstructed the ACL yet. We just reconstructed the ALL. The pivot is gone. There may be a glide, but certainly no shift. And so I do that in every case now. I'll do a little video before, and then I'll do a video after we reconstruct just the ALL, just to confirm that we've gotten rid of the pivot. And then we'll do one final video after we've reconstructed both the ACL and the ALL. So this is just kind of a snapshot of the cases that our fellow did. We did 300 cases that year, 300 ACLs that year. 65% of them were just primary ACLs. About 40 revisions, and then about 29% of the 8 primary ACLs that we did ALLs with. So it doesn't, again, this is a patient specific. Every ACL doesn't need an ALL, but about 30% of my patients get an ALL, and almost all the PDs. So conclusions, the ALL really plays a real significant part in managing rotational stability and improving mechanics. Isolated ACL reconstruction does restore AP stability, but not always rotational stability. Consider this particularly in high-performance athletes, and the critical exam is really, really important. And so a lot of my cases, I'll post the cases ACL, possible ALL, because as y'all know, and I even struggle with it sometimes, you know, the patient's guarding or they're swollen or they're painful. Sometimes it's hard to get a pivot. So we do an examination under anesthesia, and they may just have a pivot glide so they get an ACL. But if they have a big pivot shift like you saw, then we're going to add an ALL. That's it. We won't go through the references. Thank y'all. Any questions?
patient of an ALL, how much does your therapy protocol change?
Not at all.
Not at all.
Not one lick. Because it's rigidly fixed. So the swivel lock, you drill a tunnel about 1 millimeter larger than your graft. So if I say have a 5 millimeter, so I usually use a gracilis autograft. If the semitendinosus is big enough for the ACL,